for this 3 hour session on this very, very important day of your conference, the beginning of your conference, for this live surgical session and some presentations. So I'll begin with some basic surgeries which I have not done in Bangladesh earlier. I know I have been there a couple of times, did some sinus surgeries, angiofibroma, tumors and other things. But this time I am connecting with some basic surgeries from our theater, which we come across in our practice almost every day. Before that, I'll have just 5-10 minutes presentation as I received a couple of calls from Bangladesh regarding concepts of radiology on diagnosis of fungal sinusitis. So I'll connect, I'll speak on a couple of slides first. Live case is getting ready, and then we'll come to the first case, a beginner, very important in our practice, that is endoscopic adenoidectomy. So before that, I'll just throw some light on diagnosis of fungal sinusitis, the value of radiology in differential diagnosis and management, optimal management of fungal sinusitis. So can you connect my laptop, please? Are you getting my slide?
Yes, sir, we are getting you very much. No
Okay.
issue.
Thank you. So I hope the picture is good there.
Yes, it is.
So as far as fungal sinusitis is concerned, there is a very common pathology in our clinical practice. And you know, radiology has a big role in differential diagnosis and management, optimal management of this disorder. By and large, there are 4 varieties of sinusitis, fungal sinusitis. The least botherful is the fungal
Satish,
ball. Yeah.
Satish, just 1 second. Morila is here. Can we record your video?
Yes.
We have to have your permission to record it.
Okay. We are recording.
Yeah. We like to have your permission to record your deliberation.
Yes, yes.
Okay.
So, by and large, there are 4 varieties of fungal sinusitis, 2 being non-invasive, other 2 being invasive, and both have differential, as far as the diagnosis is concerned, it is different. The prognosis, management, each and everything is different altogether. So, correct diagnosis is the key for the optimal management of this disorder.
Your technical man has not accepted recording request. Please tell him to accept it.
Sir, yeah, hi sir, we are already recording. I will share you the recording file.
Okay, sure.
Thank you.
Sir. So, what I was saying, there are by and large 4 varieties of fungal sinusitis. Common in our clinical practice, their optimal diagnosis is the key for the optimal management. If we divide into categories, by and large, there are 2 varieties of non-invasive fungal sinusitis and 2 varieties of invasive fungal sinusitis. You know, pathology is not always required for the diagnosis. Before pathology, it is the radiology which gives you full insight into the correct diagnosis so as correct management. So in 2 varieties of non-invasive fungal sinusitis, the simplest one is the fungal ball. Fungal ball means when we inhale, we inhale the air and fungus is ubiquitous in the air. When we inhale the fungus, sometimes it gets trapped into one of the sinuses. And it gets multiplied, it keeps on collecting, not able to pass through the mucociliary clearance and ultimately block the sinus and become symptomatic. But this is non-reactive, simple, non-invasive fungus. It doesn't need any major treatment but to remove that fungus by means of sinus surgery, endoscopic surgery, and establish the ventilation and drainage and forget about it. That's it. So that's the simplest aspect of fungal sinusitis one can think of. The second variety is very important in clinical practice, is allergic fungal rhinosinusitis. This is very important. See this. This is classical picture of allergic fungal sinusitis, which is found usually in younger patients mostly unilateral, and there are characteristic, heterogeneous hyperdensities in the paranasal sinuses. You can see on the screen. That's a classical picture of allergic fungal sinusitis. This is non-invasive again, but the way it expands into the sinuses and gives bone erosion, it gives you a suspicion or gives you a look of invasive fungal sinusitis. But it doesn't invade. It's pure non-invasive fungal sinusitis. And the pathology, how it starts, like we inhale the fungus, when we inhale, if the individual is allergic to any fungus, which he happens to get trapped into the sinuses, it keeps on giving reaction. The human body's reaction come into the action, eosinophils come into the action and secrete the classical eosinophilic material around the fungus by means of extreme allergic reaction. That's a type 1 hypersensitivity to the fungus which is trapped in the sinuses. And this fungus, along with the allergic mucin consisting of degraded eosinophils and other things, blocks the sinuses and starts a vicious cycle wherein the mucociliary activity is blocked, things do not drain into the nasal cavity, and a vicious cycle starts and keep on collecting, and it leads to expansile bony erosion of the paranasal sinuses. This is classical of allergic fungal sinusitis. This heterogeneous densities you would see in the paranasal sinuses, enlarged paranasal sinuses, ballooning of the paranasal sinuses, bony erosion at the places where it is expanding to the walls of the paranasal sinuses, maxillary, ethmoid, skull base, orbit, everywhere. But it doesn't invade the mucosa. So still it is not invasive, giving a picture of like invasive fungal sinusitis, but it is not invasive fungal sinusitis. This is very, very classical of this allergic fungal sinusitis, and here the management is altogether different. Since being non-invasive, you don't need antifungal. This is important for the diagnosis. Fungal sinusitis means a medical disease for which medicine is the treatment. But here it is type 1 hypersensitivity reaction to the fungus, antigen antibody reaction. And like any antigen antibody reaction, steroid is the mainstay of treatment, not antifungal. So since it has blocked the paranasal sinuses and given off a vicious cycle, the treatment is a full house fast, removing all this fungus material, cleaning all this eosinophilic material which is collected as a part of reaction, removing all fungus which is acting as an antigen, and giving wide openings to the paranasal sinuses for the future drainage, as well as surveillance, as well as introduction of topical steroids. Since it is allergic antigen antibody reaction, the mainstay of treatment is steroids, not the antifungal. So the importance of the diagnosis is not to unnecessarily start any antifungal. There is no point in starting any antifungal. The role is of a full house fast, removing all this antigenic material, removing all eosinophilic material, establishing ventilation and drainage of the paranasal sinuses for their good health in future, allowing big openings for the future surveillance, and the most important is allowing the introduction of the steroids freely into the paranasal sinuses to combat this antigen antibody reaction in future and prevent recurrence. But there is no role of antifungal at all. See how important it is in diagnosis. You have a fungal disease, but no need of antifungal, being it is a non-invasive disease. So that is how the diagnosis is so important. The third diagnosis, the third variety of fungal disease is a chronic invasive fungal sinusitis. It's a different entity. The difference from the non-invasive fungal sinusitis is here the fungus invades the underlying mucosa and go extra sinus. How you can differentiate, though it is the gold standard for the final confirmation is the histopathology. The histological proof of invasion of the paranasal sinus mucosa by the fungal hyphae is the diagnostic, final diagnosis. But on radiology, it gives you a huge clue Use information to plan your surgical process accordingly. What I mean to say, look at the radiology first. In chronic invasive fungal sinusitis, the sinuses as compared to the invasive allergic fungal sinusitis, as compared to that, sinuses are not expanded. There is no expensile collection into the sinuses. Since it invades the sinus mucosa and the underlying bone, there is bone erosion, and through that it goes to the other cavity outside. And here the other cavity is orbit. The disease has expanded to the orbit. There is minimal disease in the paranasal sinus, underlying bone erosion at the adjacent region, and then expansion into the orbit everywhere. Expansion on the orbit everywhere. And this is classical of invasive fungus. Why it is important on pre-operative radiology as compared to the allergic fungal sinusitis, wherein the mainstay of treatment is a full house fast to remove all the fungal antigen. Here the mainstay of treatment is not full house fast. Here the role of surgery is very, very limited. Limited in the sense, the role of surgery is to prove the mucosal invasion by the fungal hyphae to establish as a chronic invasive fungal sinusitis, which is mostly attributed to the aspergillus. So the role of surgery is to take a biopsy, a specimen to prove mucosal invasion by the fungal hyphae. And second, if there is any blockage of, paranasal sinus mucosal drainage and ventilation, you can re-establish the ventilation and drainage. There is no point in doing a full house fast. It's a pure medical disease. The treatment of choice is antifungal. And for this particular aspergillosis, invasive aspergillosis, voriconazole is deadly. So voriconazole is the drug of choice for such disease, not the surgery. See why I'm putting the radiology in front to discriminate the diagnosis. The moment you see this kind of a picture, you don't need to plan a full house fast. You just need to plan a biopsy to prove the fungal invasion of the mucosa, re-establish the ventilation and drainage if the sinus is blocked. No need to remove the entire fungal mass. It will be taken care of by the voriconazole once it is established as a chronic invasive fungal sinusitis. So the radiology has a key role in planning the surgical exercise. You don't have to plan looking at the CT scan from beginning, a full house fast, like in the previous picture. See in this, the moment you see this kind of a picture, the plan is straightforward to plan a full house fast to remove all these antigen, eosinophilic material, establish mucosal drainage and ventilation drainage, and then introduce the topical steroid. But in this picture, you don't need to do anything. In such, you need to plan just biopsy and then introduce the oral voriconazole as an antifungal antifungal treatment to cure this disease. See now, another example, minimal ethmoidal disease, and see the adjacent orbital invasion. More examples, see this minimal ethmoidal disease and massive orbital invasion, minimal paranasal sinus disease, looks like a tumor or something in the orbital apex. Take a biopsy and it proves as a chronic invasive aspergillosis, and you don't need to, do any radical removal of this fungal mass from the orbital apex. You just need to take a biopsy. If it proves to be a aspergillosis, the voriconazole is the treatment of choice, not removal of this fungal mass. That is the, I would say the main treatment for this disease in this context. This is very, very important on radiology. Again, example, see this minimal paranasal sinus disease and maximal extra sinus invasion into the orbit. And again, you don't need to remove it radically. Once you suspect on the basis of radiology as a chronic invasive fungal sinusitis, the next is the treatment. Next treatment is take a biopsy and introduce voriconazole as a final treatment for this disease. So it is important to know minimal intrasinus disease, adjacent bone erosion, maximal extrasinus disease. Take a biopsy and prove to be a chronic invasive fungus. And once it is proven, you need to introduce voriconazole, not the antifungals as such. So this is very important. Very important. See this? It looks like invasive fungal sinusitis, expansile bone erosion, but this is pure allergic fungal sinusitis. This is non-invasive. So invasive fungal sinusitis will show minimal sinus disease. Non-invasive fungal sinusitis, on the contrary, will show maximum sinus disease, full paranasal sinuses full of fungus with expansile bone erosion. That's a gross difference which you can make out on the radiology, and then you can plan your surgical exercise and the medical treatment accordingly. So, how important the radiology in the diagnosis of such pathologies to optimize your outcome. And the last variety of fungal sinusitis is the mucormycosis, which is called as a acute fulminant, you know, invasive fungal sinusitis. We have seen the epidemic of mucor, and here what we believe, we have done more than 800 cases during that epidemic and learned a lot of lessons. And some of the important things I'll just highlight, throw a light on those issues. For the role of MRI, what we believe, it is the MRI which is life-saving in mucormycosis. Life-saving not only for the diagnosis but also for planning the surgical exercise. Mucor being an invasive fungus with a predilection to invade vessels and giving vascular necrosis. Wherever it goes, invade the vessels, block the vessels and give ultimately vascular necrosis. And invasive fungus, like the previous entity of chronic invasive fungal sinusitis, being medical entity, the treatment of choice is medical. And for this, the liposomal amphotericin is the drug of choice. But since it gives vascular necrosis, the penetration of amphotericin is the question mark. So what we get out of the contrast MRI is the ability to choose the cases for the medical treatment, ability to select the cases for the surgical treatment, the necrotic area where there is no vascularity. You need to remove them surgically to able to make the medical treatment effective. So how the MRI is game changing? Once you do a contrast MRI, when you give gadolinium as a contrast, those areas which are enhancing, where the gadolinium is reaching, your amphotericin is likely to reach, and is it deadly? It is going to give cure. But those areas where gadolinium is not reaching even, which is not enhancing on contrast, your amphotericin is same, not likely to reach there. And those are the areas which need to be extensively debrided. Remove that gangrene. It's a sort of gangrene dead area to make the medical treatment effective, to make the enhancing areas, penetrable by the amphotericin. See the few examples. See this patient. See this turbinates on this side, the normal side, on contrast, they're enhancing. On the other side, see the turbinates. It's all necrosis. On the opposite side, it's all necrosis. And in those necrotic areas, even if you try to give the best of the antifungal, in the best of the doses, with all, due care, the antifungals are not going to penetrate, and those are the cases for surgical debridement to make the medical treatment effective. So the role of MRI is not only to select the cases for surgical debridement, not only to select the cases for medical treatment, but to guide us the extent of surgery as well. That is most important. Only those areas need to be thoroughly debrided which have no vascularity. See this in the next picture on the right side. See this, all enhancing areas need not to be debrided. Enhancing means your gadolinium is reaching. You don't need to, unnecessarily resect and give morbidity. Only those areas need to be debrided where the gadolinium is not reaching and giving dark areas. Lack of contrast enhancement is the key to, guide the surgical resection. So MRI is the key. How extensive the surgery should be, whether the surgery is required or not, what not to be removed. All enhancing areas should be spared to prevent unnecessary morbidity. Only non-enhancing areas need to be debrided. And see, there are a lot of examples. Only non-enhancing areas need to be debrided, even if it is involving, see this, this side LI is involved, entire soft tissues are involved, premaxillary soft tissues are involved, whatever. Whatever MRI shows, even this ALA is normal, was normal on outside look, but the MRI shows the deep infiltration of the fungus and necrosis within it and need to be debrided. If you leave on surgical exercise after the surgery, if you leave non-enhancing areas, it is not likely to take up the amphotericin, and then this non-enhancing area is a fungal load. It's a pure fungal load, necrotic fungus, and it is likely to spread very fast. So, MRI guides you to the extent of resection. Whatsoever come in the way, if it is non-enhancing, it has to go. Whatever is enhancing need to be spared to prevent unnecessary morbidity, and that's how to make the medical treatment effective. So the role of amphotericin is to role of MRI is to select the cases for surgery, to decide the extent of surgery, to guide the medical treatment, and for the earliest diagnosis for this disease, which is not sometimes clinically apparent even on the endoscopy or outside examination. And non-enhancing area on highly suspicious diabetic immunocompromised patients with some symptomatology pointing towards it. Non-enhancing area on contrast administration after this thing MRI is diagnostic of mucormycosis at the earliest stage. Earlier the diagnosis, better is the cure. This disease, as I said, is acute fulminant. It spreads in no time. If the disease remains undiagnosed because of the difficulty in getting MRI or not accessibility to the MRI or not getting a good contrast MRI done, is detrimental to the patient, and then you can't expect a good cure because it advances very fast to the orbit and then to the brain, and it has a definite fatality in certain percent of the patients. So early diagnosis is the key, and mucormycosis for this disease, the contrast MRI is game-changing, it's life-saving, not only for the diagnosis, but for the management, prognosis, extent of surgery and everything. Any questions regarding this before we move on to the live surgical session, sir? Hello? बोलना वॉल्यूम बढ़ा है. Hello?
No question, please. Continue your lecture.
So move on to the live surgical part with the first case. Hello?
Please proceed your lecture. No question right now.
Your voice is not. I'm not able to hear properly. Can you repeat, sir?
No question right now. Please continue your lecture. Or proceed now. Light surgery now, please.
Okay. So we go ahead with the live surgical part.
Yes. You should start with live surgical part, please.
Okay. So let me tell you to begin with. As I came to know, there are a lot of junior colleagues coming today to attend this. So I kept some basic cases, and to begin with, a very interesting situation, which a lot of implications in our clinical practice as far as the outcomes are concerned, and that is the hypertrophic adenoids requiring adenoidectomy. Let me tell you, this is one of the commonest surgery, and we have done thousands of such cases and brought out our own technique to optimize the results, looking at various implications of this disease. So, hypertrophic adenoids are prevalent in children, and that is one of the indications for adenoidectomy. But believe me, this in our practice is I would say, less prevalent indication than other two indications for adenoidectomy in your practice. By and large, there are three indications for adenoidectomy. One, which I am going to show you, is for the obstructive regions. That is the commonest, the child coming with the complaints of mouth breathing, and in the young growing child, if not treated, can lead to facial deformity, classical adenoid faces, and other issues. So that is one of the commonest indications for the adenoidectomy in our practice, so which I am going to demonstrate. And this is important to treat these children as early as possible at the younger age to optimize the outcome, to prevent the complications. The other two indications for adenoidectomy are non-obstructive. And believe me, if we are thorough in our workup, suspicious at our diagnosis, those are more rewarding and more useful to optimize the treatment of those two conditions, non-obstructive. Number one, sinusitis in young children. You know, in adults, sinusitis is what? Involvement of or the mucosal inflammation lining the paranasal sinuses. And for that, endoscopic sinus surgery is the mainstay of management if it doesn't respond to medical treatment. When the disease load is too much to be tackled by the medical treatment or maximum medical treatment, we advise or we undertake the functional endoscopic sinus surgery. In children, functional endoscopic sinus surgery for sinusitis is not the primary alternative for the reasons which are all very obvious. In children, the anatomy is challenging, the structures are very close to each other, the distances are very close to the critical structures. And the more important thing in sinus surgery, the final outcome depends upon the post-operative irrigation. Need of long-term irrigations for the regions, for the endotype for which we are operating. In children, most of the sinusitis is not eosinophilic as compared to the adults. In adults, mostly it is eosinophilic. In children, it is mostly non-eosinophilic, or you can say neutrophilic, for which medical treatment is the key. And now it has been proven the adenoids harbor biofilms which keep on releasing virulent bacteria from time to time, and they sustain or aggravate the symptom of sinusitis in children. So it has been proven now with a lot of studies, meta-analysis, when the sinusitis in children is not responding to the medical treatment, once it comes to surgery, the first line surgery we should advocate should be adenoidectomy, not sinus surgery. Adenoidectomy, by means of adenoidectomy, removing the biofilm, remove the source of biofilm, and it helps in, treating the sinusitis in pediatric groups with a medical treatment better. It has been seen on culture reports, culture studies, the same bacteria which are in the biofilms are found in the paranasal sinuses. So by means of removing biofilm, we remove the source of those bacteria. As I said, it is mostly neutrophilic, not eosinophilic as compared to the adult sinusitis. This adenoidectomy is a very, very effective treatment in pediatric sinusitis not responding to medical treatment as compared to the adults. So adenoidectomy is one of the mainstay of treatment for pediatric sinusitis not responding to the medical treatment. And you know how this problem remains underdiagnosed. Pediatric sinusitis is difficult to diagnose for the regions. Pediatric patients do not present freely with the symptoms like adults. The symptomatology or signs in the pediatric, age group of nasal disease or sinus disease are overlapping the symptomatology of other disease like viral infection, upper respiratory infection, or other, infections in that region. So symptomatology is overlapping, and one can, overlook the main sinusitis which is responsible for the problem. And third is not a habit, not a routine to advocate CT scans in the pediatric age group because of the reasons of the radiation hazards and so. So the diagnosis of pediatric sinusitis is almost always, underdiagnosed, I would say. And these patients require optimal removal. And if they don't respond to the medical treatment, we must get a CT scan to prove this. We must look at the adenoids and do an adenoidectomy in spite of adenoids not being enlarged. What I'm talking of indications of adenoidectomy when the adenoids are not too large to block the airway. So non-obstructive indication, the number one being the sinusitis, pediatric sinusitis, in spite of adenoids not being too large to obstruct the airway, yet they need removal for the reasons to treat the sinusitis more effectively by all medical means. And number three, in the patients getting repeated ear issues, repeated otitis media, repeated Eustachian and tube blockages, in spite of the adenoids which are not large enough to obstruct the nasopharyngeal airway, yet responsible for repeated, Eustachian and tube malfunction, repeated otitis media. And in those cases, if adenoids are removed, they are very, very helpful in medical management of that, ear disease and improvement of the Eustachian tube functions. So these two non-obstructive indications are equally important, indications for adenoidectomy in those selected patients. And if we thoroughly assess all these patients with full suspicion of these diagnoses of sinusitis in pediatric age group and otitis media patients are all followed appropriately, the indications for non-obstructive adenoidectomy are much more in numbers as compared to the obstructive adenoidectomy. That's what I wanted to bring to your notice. It has been proven, and this is almost always overlooked, and then medical management of these two conditions becomes very, very, difficult as compared to the situations when you do adenoidectomy. So adenoidectomy for non-obstructive indications are equally important and should be, brought into your, surgical armamentarium when you are suspicious of such diagnosis in the pediatric age group. So our surgical case is ready. Any questions before that? Do we go ahead? Yes, please. Yeah, volume बढ़ाना है देखो.
Sir, they need to come near about laptop and talk.
Yes,
Their
sir.
mic audio is not coming. They need to come near laptop and talk.
Okay.
Hello, sir. Good morning, sir.
Good morning, sir.
Dr. Muntasir Mahbub from Bangladesh, sir. We all are big fans of you, and you will believe me, sir. Here are hundreds of people watching you talk, and you're probably not seeing all of them. So we are really happy that you made time for us and delivering this speech to us.
Thank you. All pleasure is mine.
Okay, sir. So another thing I wanted to mention, sir, I was just in India and I came here today, like 1 day before finishing my course there, just to see you here. But although you are not here, but seeing you like this has made this all worth it. We miss you, sir. We all miss you, sir. So one question, sir, here is that, sir, we all have seen the microdebridal adenoidectomy video that you put out on YouTube, and we have learned a lot from there. So what's your opinion, sir? Here currently in our ENT community, we have a debate of coagulation adenoidectomy and microdebridal adenoidectomy. So,
I definitely, your question is valid, and that's why I put this surgical case in order. There has been a lot of debate regarding the, the surgical tool for the for the adenoidectomy. Microdebrider, adenoid curate, coagulator, harmonic scalpel, cautery. There are so many ways to remove this hypertrophic adenoid tissues. We need to know the pros and cons of all, and that's why I kept this case, and that's what I'm going to discuss during the surgery. Coagulator is very useful for hemostasis. Microdebrider is very useful for debridement of this tissue. When to use what for the optimum results is the key. And that's what I'm going to show you during surgery.
Thank you, sir. Another thing I want to mention is, sir, in KKR ENT hospital, when I was there, I met Dr. Shibham Sharma, who is a dear junior to you. And sir, you remember Dr. Shibham Sharma from Jaipur, sir? Dr. Shibham Sharma.
Dr. Shubham?
Shibham, yeah, Dr. Shibham Sharma.
Shibham, yes.
Yeah, I was there in KKR ENT hospital, 15 days with him, and we used to talk a lot about you, how you do your operations, how your center operates, and what facilities are there. So, I mean, sir, if we could learn from you, that would be a very great opportunity for us. And sir, thank you, sir. Thank you for today.
Thank you. Thank you once again. and let's get on to the live surgery now. वो लगाया? लगाया? फिर क्या? वो नीले है? स्पीकर नहीं देता थे अక్కడ वो नीले है स्पीकर हाँ उनके पास ना सर वो उनके पास डाल के सामान देखिए हेलो
Hello, sir. Can you hear us, sir?
Yes, very well.
Sir, we cannot see actually.
We are starting in a minute's time. So,
Okay, sir.
stay with us. Camera on, oh, got it. Okay. चेक कर लीजिए वो लगा दी रुक जाओ मैं गाँव नहीं पहन रही बाद में नहीं रखता है Hello. Hello.
Hello, sir. Can you hear us, sir?
Yeah, I can hear you. Are you getting any endoscopic picture?
Yeah, we are seeing now. It's a nice view.
How is the picture?
The picture is good, sir.
See this. This is the right nasal cavity. Is a young child. This is the left nasal cavity, and we packed with the saline adrenaline solution to open up the nose to decongest this to improve the nasal passage for our instrumentation. Can you see that?
Yes, sir.
And these are the adenoids after decongestion. See the
What is
adenoid?
the age of the patient, sir?
Can you see this?
Yes, sir.
Age is 4 years.
Okay, sir.
And this is the picture after decongestion of the nasal cavity. I am still using 4 mm telescope through the nose. Can you see?
Yes, sir.
So our technique in this is to use the endoscope from the nasal cavity and our microdebrider and cobbletter from the oral cavity. See this.
Sir, which size of endoscope now using?
Yeah, this is 4 mm, 0 degrees 4 mm. In young children, sometime when the nasal space doesn't allow, we have to keep 2.7 mm ready. Okay. Now this picture is after decongestion from behind. Lot of topical decongestion we have done. Lot of topical but no infiltration at all. Once again, I'll show you this topical decongestion from behind. See this?
Yes, sir. We are seeing.
This topical decongestion from behind once again. So more and more topical decongestion. To decongest the adenoid surface. See, our goal in this case is to remove the adenoids in toto. Many a times, adenoids is what? It's not a tumor. It is just hypertrophic lymphoid tissue, which is part of the Walder's ring in the upper respiratory airway. Okay? Once they get hypertrophic, infected, allergy, all these things promote the allergic, this adenoid hypertrophy, and then they are responsible for the symptoms. So our goal here in this case, the patient present with obstruction, our goal is to do a comprehensive adenoidectomy. Our goal is to remove adenoid, not to damage anything else. We have to be careful not to damage the soft palate. We have to be careful not to damage the eustachian tube, pharyngeal muscles behind, and any other structure in the vicinity. Our goal is solely and solely to remove the adenoids. Secondly, we get many a time patients with recurrence of adenoid. Very funny situation. As I told you, this is not tumor. This is hypertrophic lymphoid tissue which responds to allergy and repeated infections. So goal in this patient is to remove the adenoids comprehensively, followed by comprehensive allergy and infection treatment which are responsible for this. It is not like you do the adenoidectomy and forget for this ever. They are almost always associated with allergy. And that's how they become hypertrophied. So the treatment after adenoidectomy is to be followed with the anti-allergic and the immunity and the infection management to prevent the so-called recurrence, so-called repeated hypertrophies. Number 3. Yes. Yes. Hello.
Hello, sir.
Yeah. Any question?
What is the position of the patient, sir?
Position is regular, 15 degree, 10 to 15 degree head up, reverse Trendelenburg position like you do for the sinus surgery. Same. I am with a 0 degree inside the nose and my instrument will come from oral cavity. So,
Sir, is there anything under the head or not?
yeah. It's a
Any
ring
pillow or
under the head, ring under the head, and the head end is raised by 10-15 degrees.
So what is the preparation used for decongestion?
Topical decongestion, we use saline adrenaline. Being young patient, we use more concentrated as it is pretty safe in for the topical use. We are not infiltrating anything. And a single first application decongests the nose to prevent their further absorption. So the topical use, even being, even if you keep concentrated, is it pretty safe? Now my surgical exercise will start with removal of the adenoids, and which I will accomplish in 3 phases. 3 phases means the goal is comprehensive removal. 3 phases means my first phase is gross removal of the adenoids. This I will accomplish fast by means of micro debrider. I will tell you the reason this phase to be done with the micro debrider. Why? In spite of a little bit of the bleeding which micro debrider is going to give, still I will prefer to use micro debrider so that I don't lose my plane. Because my second phase would be removal of this adenoids completely from the posterior nasopharyngeal wall musculature in the plane, in the fascia plane covering the muscles behind. That is very, very important. I need to preserve that fascia to protect the muscles behind. In order to remove the adenoid, if I happen to damage the musculature behind, the complications are invited. Complications of nasopharyngeal cicatrization, stenosis, nasal twang, infection, torticollis, even abscess can happen when you damage unnecessarily the posterior muscles. As I told you in the beginning, the goal is removal of adenoids, not to damage anything surrounding. That's why the role of microdebrider comes into the play in the beginning, in spite of the little bit bleeding it gives. Yeah. So, in spite of the little bit bleeding, we prefer using microdebrider at this stage so that we don't lose the plane. Suppose if I happen to use the cobbleter at this stage, cobbleter will inevitably charge the perimysium and the muscles underneath, and then you can't get into the plane. We don't want the muscle to be charred at all. Cobbleter is a very useful tool in the second phase to tackle the vascularity, to tackle the bleeding, to tackle the to achieve the hemostasis, preserving the perimysium and preserving the musculature behind. So my first phase, which obviously is going to give little bit of the bleeding, I am still going to go with the microdebrider for the reasons I told you. The reason is very obvious: to get into the plane later. Is that clear?
Okay, sir.
Hello? What?
Yes, sir. We are here.
Yeah. So my first phase now, I am starting with the microder. पानी डालना ऊपर से. हो रहा है. See this. I am bringing my microdebrider from below. See this red 60 microdebrider. Can you?
Red 60, sir. Okay.
Red 60 sinus blade. We condemn using adenoid blade. Adenoid blades are rear facing blades.
Yeah.
They can damage the tissues behind. See this. I will accomplish this removal of the tissue very fast, as the bleeding is going to happen a little bit. So I accomplish very fast and remove this surface adenoid. Gross removal. Can you see this?
Yes, sir. We can see.
Quick. It has to be very quick so as to minimize the bleeding. The only disadvantage of this technique which I am going to show is this minimal bleeding, which is not going to give any problem to the patient as it is too minimal. But still, just the proponent of cobbleter people, we can say that they can do the adenoid active bloodless, but doing that, they'll end up damaging a lot of, perimysium and the muscles behind, which is not acceptable at all. See from the opposite side. This is luminal clearance. With this?
Yes, sir. So now you are using, sir, the sinus blade 68.
Yeah, red 60 sinus
And-
blade, nothing
And
else.
for final removal, you will use the adenoid blade, right, sir?
Yeah, no, not removal. I will show you.
Okay, sir.
See this. See this final, after the first stage, this is luminal clearance. Luminal clearance of the adenoid, and see the airways opened up. Can you see?
Yes, sir.
This is the first phase with little bit of the oozing. At this stage, I will just pack for a while, couple of seconds, with the same saline adrenaline pack to minimize this surface oozing. Just for a while, for a couple of seconds, a light saline adrenaline pack. This is to control the surface oozing so that we can move on to the second phase. What we achieve with the cobbleter, microdebrider at this time, quick removal of the luminal adenoids to open up the airway, no damage to the underlying perimysium or the muscle, and now it will give us the ability to get into the right plane for the complete removal. If I happen to char everything with adenoid, now I will remove just 10-15 seconds and remove. See, just 10-15 seconds and remove. That is more than enough. See the initial picture after the first stage. Can you see?
Yes, sir. It's nice to see.
After the pack, there is hardly any bleeding. And with this kind of removal, you feel like,
Sir, you are using hot water? Is it hot
Water?
water or normal
no,
water?
no, regular, not warm water. This is not warm water. Now see my second phase, very critical, very important. And that is the advantage of doing with the microdebrider first phase. See this? This is oropharyngeal mucosa below. See this? Below
Yes.
is the oropharyngeal mucosa. Can you see the plane?
Yes, sir.
Above is the adenoid tissue which is there on the muscle. And in between them is perimysium. So what I will do now with the second stage, see this. Gently using this at this mucosal junction. Tangential use of this blade to get into the perimysial plane. Oi. See, I am trying to get it. See, I am trying to get into the right perimysial plane with this tangential blade. Can you see the perimysium below?
Yes, sir. We are seeing.
See this. The beauty of this blade is this is not rear facing blade. See my perimysium behind, very clear?
Yes, yes. It's clear.
In plane with the mucosa. See, very clear?
Yes, sir.
All this tissue above the perimysium with this red 60 now, see? The rear surface is not cutting surface. It protects your perimysium and you can remove all this adenoid tissue very quickly without damaging the perimysium. If your perimysium is intact, your muscle is pretty safe. Can you see?
Okay, sir. Yes, sir.
See, all these adenoids are coming so easily. Coming into the blade. This is in the midline. I am seeing so much of adenoids even after the first phase, which was looking like complete removal as far as the airway obstruction was concerned. See this?
Yes, sir.
Keep going up in the perimysial plane. My plane is, see, this is perimysial plane. See, with the debrider, you don't char the perimysium. That's the only reason for using the micro debrider in spite of the minimal bleeding it gives. See this? See this?
Yes, sir.
Now, as I go up, see, this was the muscle layer behind. Can you see this? I can feel it. See this muscle layer?
Yes, sir. It's nice, sir.
Here there is no
Very
muscle.
nice view.
Here there is no muscle. This is the Beji occiput now. See, I can feel no muscles behind now as I go up. Only Beji occiput, and now here I can do hard combing. There is no muscle behind. Only periosteum, which is quite resilient. It cannot come in micro debrider. See this? This is called hard combing. Hard combing and removing each and every bit of the lymphoid tissue. See this? There is no chance of damaging muscle above. There is no muscle above. It is pure periosteum, so I can afford to do this hard combing. Can you see very clear?
Yeah, it's very clear, sir.
See, until here is the muscle. Above there is no muscle. See now in the second phase, this is the muscle and the perimysium above. This is the muscle and perimysium, and above is the periosteum only. See now, after removal of the adenoid, only periosteum. Coming from the opposite side, with little DNS on this side. Same thing I am accomplishing on this side as well. See this? Hard combing above. I can feel my debrider blade against the base occiput. Can you see this?
Yes, sir.
This is complete removal in the midline. Very clear. This is your perimysium and this is your base occiput. See this?
Yes,
Here
sir.
I was gentle in the perimysial plane and here I was, hard enough to remove by means of combing using this micro debrider from the periosteum. So now it is very clear. This is my after the second phase. See this? See this?
Yes,
Below
sir.
is the mucosa and this is the perimysial plane. Little bit of the oozing. I will take care. Now comes the role of coagulator. Until now, I didn't use the coagulator for the regions. The reason is obvious, to prevent perimysium and the muscle being charred unnecessarily. That I would never want. That is not our target. If your perimysium and muscles are charred, the nasopharyngeal afterwards stenosis, cicatrization is imminent, and those poor children unnecessarily suffer with the nasal twangs, infection, and a lot of things. In order to prevent that, so far I was avoiding coagulator. This was my second phase. The third phase is still to come for the laterally hypertrophic adenoid. Yes, please. Any questions? See this.
At present, no questions, sir.
Sir, one question, sir. We see there is a active bleeding in the near the periosteum. So how do you coagulate this bleeding? Do you use any coagulator or not?
Near the bleeding, near the
Near the periosteum.
near the periosteum, coagulator you can use over the periosteum. I will show you. I will show you. See now, after my pack, hardly any bleeding.
It's okay, sir. No bleeding, sir.
Now see what I am trying to show. This perimysium covers the muscle. If there is any bleeding from the muscle, the perimysium, that can happen only if the muscle is breathed. This perimysium is breathed. As long as perimysium is intact, the bleeding cannot come from the muscle. Got my point?
Yes, sir. It's a
So
very good
all
point, sir.
post-operative hemorrhages in adenoidectomy. See this, even the smallest one, I can use my, see this Procise Max vent. See this?
Yes, sir.
And you can control that easily. The goal is not to damage the underlying muscle at all. Now, what I'm trying to say, in spite of being a dry field now, still there are chances of post-operative hemorrhages. From where? From the periosteal region. The reason being, it is rarely from the muscular region because muscles contract, periosteum do not.
Yes, sir.
All post-operative adenoidectomy, post-adenoidectomy hemorrhages are from the periosteum. In order to prevent that, now I will do extensive, carpet coagulation to the periosteal region. See this? This is called carpet coagulation. Can you see this? Since there is no muscle underneath, it is absolutely harmless. Can you see?
Yes, sir.
But this is a sort of insurance to avoid the post-operative hemorrhage. I am not doing carpet coagulation below, here on the muscle. To prevent charring of this muscle and the periosteum, we resorted to microdebrider in spite of the little bit bleeding goes on. Can you see this?
Yes, sir.
This is carpet coagulation because all post-operative hemorrhages can come only from the periosteal region, not from the muscle. See this, how it looks. There is no question of post-operative bleeding once you do this carpet coagulation of the periosteum layer. Can you see this?
Yes, sir.
So this is intentional carpet coagulation. So there was a question in the beginning when to use what equipment. Both equipment, coagulator and microdebrider is good. You should know when to use what. See this carpet coagulation. This is Eustachian tube orifice. This is Eustachian tube per se. We are not supposed to damage the Eustachian tube. This is torus. This is the Eustachian tube orifice. The beauty of the endoscopic adenoidectomy is we do under vision and we can protect these structures very, efficiently. So this is carpet coagulation of the periosteum layer. This is oropharyngeal mucosa. This is nasopharyngeal, perimysium and the muscles behind. Very clear?
Clear, sir. Sir, in
Now-
this periosteal region, can you use diathermy, bipolar diathermy?
Bipolar you can use, but the beauty of the coagulator is
There is no muscle.
the lack of collateral damage. This is always associated with the irrigation, so the final temperature rise is not beyond 60 degree or so. If you use cautery or anything, that is more damaging to the tissue. So we prefer coagulator as our main tool for this to prevent collateral tissue damage. The whole idea is to prevent damage to anything besides adenoid. What's my point? What I said in the beginning. Our goal is to remove adenoids, not anything else. Remember?
Yes, sir.
Yes, sir.
So now my two phases are over and it looks like fungal. It looks like my adenoidectomy is accomplished, but still my third phase is pending. See my after two phases?
Yes, sir. You want to see face endoscopic sinus surgery.
There is two phases. This is perimysium and the muscle behind. That is periosteum above, which is, and see this periosteal vessels can be gently coagulated. Not to do any thorough, coagulation unnecessarily to prevent charring of the muscle. See, my muscle charring is almost zero. Can you see? Now
Yes,
my
sir.
third phase. Third phase is adenoids, laterally hypertrophic adenoids. How you can see this? This is very, very important, which are responsible for the ear problems. They can regrow and obliterate the space. Can you see this?
Yes, sir. We are seeing.
Laterally hypertrophic adenoids. See the chunk of. And the fear is the damage to the vessels and all. Let me tell you our technique, simplest. See the press on the posterior muscles. See this?
Yes, sir. We are seeing. Sir.
Same blade,
Same blade.
not cutting from behind. Same blade, under vision, not to poke anything beyond visualization. Allow the adenoids to fall into the blade. See this. See this? That's the plane. See this laterally hypertrophic adenoids?
Yes, sir.
This is behind the torus. I am behind the torus. Can you see?
Yes, sir.
I am not poking anywhere my blade. Absolutely under vision. See this? Only perimysium there behind. Can you see?
Yes, sir.
All adenoid tissue is going to jump and fall into the blade. See, there's a lot of adenoid tissue still there. See the amount of adenoid tissue which is falling.
Sir, are you working in the fossa progemolar, sir?
And this is responsible for the persistent problem if not taken care of. See this?
Sir, are you working in the fossa progemolar?
This is fossa Rosenmuller area. Fossa Rosenmuller is still far, deeper.
Thank you, sir.
See, it is completely cleaned off. Can you see? See the musculature laterally. See, this is lateral musculature. Can you see?
Yes,
Hello?
sir. Yes, very nice view, sir.
See, without damaging any muscle, a lot of people have a fear of damaging the vessel, carotid artery and all that. See, there are two thick muscles which separate from the parapharyngeal space. Longissimus capitis and levator. These are the two muscles, rectus capitis anterior. These are the two muscles which separate from the parapharyngeal area, which cover these two thick muscles, cover the carotid artery beside the periosteum. See now, the entire fossa of Rosenmuller has opened up laterally. Can you see?
Yes, sir.
Gently. It is very, very safe, provided you don't poke into it blindly. You just press on the muscle. See this muscle? Rest of the superficial adenoid automatically fall into the blade. Your goal is very clear. We are not supposed to anything forcibly introducing in this region blindly. See this all opened up. And these are the adenoids which are responsible for persistent ear problem, and even they can regrow to the bigger size to obliterate the entire nasopharyngeal airway. Can you see this?
Yes, sir.
It is completely opened up with hardly any bleeding. Very, very safe. I can leave on a adrenaline, sponge for a while. We go to the opposite side. I hope it is very clear.
It's very clear.
Now going 30 degree. Now 45 minutes. Now going to the opposite side. Okay.
Yes, sir.
Same way, like we did, same way we'll remove from the opposite side, and you will find, see this, from the nasal cavity. Mind it, our goal is to remove the adenoids only, nothing else. See that?
Yes, sir.
Our goal is to remove the adenoids only, nothing else. अनुपम का है वो फेशियल नर्व वाला केस लगा लो, फेशियल नर्व. See this picture? No bleeding at all.
Yes, sir.
Now going to the opposite side. Hold on. See the opposite side?
Yes, sir.
It looks very clear, but there are adenoids behind. See this. See behind?
Yeah, we are seeing, sir.
Lot of adenoid tissue behind. Hold on. These are laterally hypertrophic adenoids which are responsible for the persistent problem. See, push your blade, keep the cutting edges in view and allow the adenoid to fall. Only the soft adenoid tissue will come and jump into the blade, not anything else. Musculature will never jump into it. See, the fossa Rosenmuller is pretty clear now.
Yes, sir.
So we have not gone anywhere laterally blind beyond the muscles or anywhere to keep it very, very safe. Very safe.
For Jumia, it is very difficult area. All are non-skill of social skills. Okay. So you should
Pardon?
be careful about this area. You should be careful. Should do carefully because the all junior colleagues are not skilled like Satish Jain. Okay. So that is very important area because
Yeah, you have to be safe. You have to follow the protocol.
if you have no angle endoscope, sometimes you will landed in the building and it will be very difficult. I'm Dr. Tushar Gandhi from Kolkata.
Sir, sir. Sir, sir. Agree with you. See, once you keep doing, you get expertise, but you are right, you have to be very, very careful in this region, particularly in the beginning. So, see my fossa Rosenmuller of opposite side.
Yes, sir.
See the transmitted pulsations of the carotid artery, which is far off, is still more than a centimeter away from here. More than a centimeter, not less than. See this.
Yes, sir.
Now, see
I have a
the
question.
panoramic,
Can you show the efficient opening?
panoramic view now you can see. This is comprehensive adenoidectomy. The adenoids cannot come back. It is not a tumor.
Yes, sir. I have a question.
See the lateral muscle. See the lateral limit. Can you see the lateral limit on either side?
Yes, sir.
Hello?
Yes, yes, sir.
Can you see the lateral limit on either side?
Yes, sir.
Very clear?
Very clear.
So this is the way one can easily accomplish adenoid. Adenoidectomy, most of the people I've seen finishing at the at the level what I did in the first stage, just luminal clearance, it is bound to give persistent problem for the region you are operating, persistent adenoid. Complete clearance means complete comprehensive clearance for the regions you are on the job. See this? How's the picture there? Hello, sir.
Yes, sir. Excellent, sir. Excellent.
How's the picture there?
Excellent.
So, could
You are
you...
using 4 endoscope, no? 4 mm 0. Dr. Satish,
Pardon?
you are using 4 mm 0, no?
Yes, 4 mm 0 degree. 4 mm 0 degree after the initial decongestion, 4-year-old child, and we have accomplished a complete comprehensive adenoidectomy for this child. And you can see the final picture. Panoramic view, bloodless. See what we have been able to achieve. We could preserve the soft palate below. We could preserve the eustachian tube orifices on either side. We could preserve the perimysium and the muscle behind. There is no question of cicatrization, stenosis or anything later on. And that has been the aim. Removal of adenoids comprehensively, yet without damaging any surrounding tissue. And this technique involves the microdebrider and the coblation as their two principal tools with the judicious use.
An endoscope.
And
An endoscope. Without
Endoscope.
endoscope, it's not possible. If only blind.
yes, without endoscope, it is not possible.
Yes.
So, any questions now regarding the surgical, technique of our technique of adenoidectomy.
Beautifully done. But one question, I'm Dr. Tushar Ghosh from Kolkata. You prefer the surgical in the fossa rosenmur area?
If you want to, as a safer side, you can leave a single layer laterally if you suspect any micro bleeding, or even if there is no bleeding, to stay on the safer side, you can use.
Yes.
So that you can use as a safer side in the fossa rosenmur.
In your career, you have any encounter in the any aberrant vessels or this area?
Not really. Sometimes, very rarely, some capillaries which you can easily, handle by means of packing with that saline adrenaline gauze for a while. Even if you want to do more and it is still a little bit of ooze, you can use coagulation very safely. Coagulation you can use on perimysium because still the muscle is underneath the perimysium. So everywhere the perimysium was intact, nowhere the muscle was exposed. That's the beauty. That's the beauty of this technique. It calls for more time than usual. It calls for more patience. It calls for more equipments. But at the end, the outcome is amazing. Once it comes to adenoidectomy, you can achieve almost 100% of what you can think of by means of this technique. So this is our own technique which I shared with you, and a lot of people have been following and getting good results. The technique has the ability to remove the adenoids completely with preservation of all surroundings to prevent any morbidity and mortality or anything.
Good morning. Kushal Majumdar.
Sir.
Yeah, the thing is that I have seen you are brave enough to go on the lateral side far away. What is the limit to avoid the stenosis of the eustachian tube area?
Chances of
Eustachian tube area. And the failure of the eustachian tube.
eustachian tube.
I have seen you are brave enough to go far laterally.
See, when you go laterally, you need to have some catch point to stay safe. Number one, press with the rear face of the blade. Rear face of this red 60 is safe, blunt. So press on the posterior musculature to get into that space. Not press on the eustachian tube, not press on the lateral musculature. Press on the posterior muscles to acquire more space and allowing the blade to reach. Retract your eustachian tube by your assistant so you can see more in-depth view of fossa rosenmuller without damaging eustachian tube. You are not supposed to damage the eustachian tube cartilage. That is very, very important with muscles attached over it, which are important to regulate the function. So the goal is not to damage anything, not to do anything forcefully, not to go anywhere beyond visualization. These are the important points. If you follow, you cannot damage anything. As far as the eustachian tube is there, it is right in front of you. As far as the carotid artery and other thing there, they are deep to thick, almost more than a thick centimeter of a musculature is there between the carotid artery and, nasopharyngeal. In rarest of the rare situations, sometimes the artery can be medialized, and still in that situation, you will feel the transmitted pulsation to keep you warned of such abnormal position. And in any given situation, even if it is, you are not supposed to go underneath the perimysium. Our final limit is perimysium. Not damaging the perimysium even. Our final limit is to stay on the perimysium to protect the perimysium. We are not supposed to damage the perimysium to damage the muscle or anything underneath. So we are one layer extra safe in this way. So keep the perimysium intact to keep everything intact underneath to prevent any possibility of infection. What happens? The most important complication is in the midline when you damage the perimysium. When you damage the perimysium, the muscle is going to bleed, by default. In order to control that bleeding, you are going to use the cobbletter, cautery, whatever. You are going to char the muscle, and that is detrimental, which can invite infection, retropharyngeal abscess. It can invite cicatrization and nasopharyngeal stenosis, nasopharyngeal, scarring, which can invite nasal twang. So all those complications do happen to occur when you cross the perimysium and damage the underlying muscle. All around is the muscle. If you protect the muscle, nothing is going to go.
One question, Professor is Dr. Tushar Ghosh. One
Pardon?
question, Dr. Tushar Ghosh. One question. Hello.
Yes, sir.
One question. You have encountered at this age of 4 years, you have removed all adenoid tissue. After 6 years, the patient presented with the nasal obstruction. And if you do endoscopy, then hypertrophy of the institution tuberosity, thorax tuberous hypertrophy, too much.
Yes.
To prevent this, you have removed sometimes thorax tuberous.
Yeah. Your question is, I got to know the why you're asking. It's a part of Walde's ring. When you remove part of the lymphatic tissue, the other lymphatics tend to get hypertrophied. That's a normal reaction. What I mentioned, what adenoids are doing, why they are getting hypertrophied? Because of repeated allergen infections, immunity, lack of immunity, and other issues. This treatment, adenoidectomy, is almost always followed in our center by treatment of allergic infection, immunity, and all those issues which led to this problem before. And that definitely prevents hypertrophy of other, lymphatic areas of the Walde's ring. That can definitely prevent. So don't tell your patient that adenoidectomy is the cure and final thing. Adenoidectomy is a very, very important part, which will be followed by management of allergy, infection, and immunity to prevent symptomatology. Otherwise, what happens? You remove the adenoid, still the symptom persists of allergy and all that. And symptoms of allergy and all that have same overlapping, symptomatology. So it should always be followed by management of allergy, infection, and immunity. That's what we always propagate.
Now, sometimes you remove the part of the institution tuberosity. If you have seen, if you see during surgery, the huge tuberosity or thorax tuberosity hypertrophy, you prefer to remove it?
There are sometimes adenoids, lymphoid tissue on the torus.
Yes.
Use lymphoid tissue on the torus. You can scrap off from the torus until you reach the mucosa. You're supposed to remove those adenoids from over the torus without damaging the torus cartilage. Cartilage is important to preserve the function of the eustachian tube.
Thank you.
Any other questions, sir?
Thank you, Satish.
Pardon?
Jain, sir. Thank you. I am Dr. Zabuza Naik from Select Medical. We are missing you very much, but thank you for your nice demonstration about this adenoidectomy. And we see clearly from India even. So we think you are now within us. We are very much interested to see the polyp surgery of fair, full house fair. Is it possible today to demonstrate?
Okay, I would keep the full house fest. Actually, the decision for this transmission was taken yesterday when I, by all exploring all means, still couldn't catch the flight because there were multiple cancellations, not one, two, three, multiple cancellations, which led to, me to not to able to board the flight, and then finally decided this. And I really could not keep the sinus case today. But if you want, I can show my previous recording and discuss on that, if you really want to do that.
That is also possible, and it will helpful for us.
Pardon?
Yes, sir.
Yes, from audience, the yes.
Yes, sir. Yes, sir.
Hello.
Hello. Is it possible tomorrow morning? Live surgery?
Yeah. Would you like to go with a live surgery or
Now live, what is now possibility of live surgery?
okay?
Tomorrow morning live surgery and now recording.
Hello. The next case I am taking up.
Tomorrow, we want to see your recording now. And tomorrow morning, live surgery. If it is possible.
Okay, I have no issues. I can show you the recording of a sinus case or a live case, which is basically cholesteatoma with facial palsy. So you have to choose one out of them. I have both the options open because we have transmission, what we have been told till 1:32. So it's up to you what you want me to show. I can show you.
We can continue even 1:30. More time. We can continue our program.
Let me know. I am ready with both the things.
Satish, Dr. Morilala is here. Satish. Hello, Satish.
Hello, sir.
Can you listen me?
Hello.
Hello, can you listen me?
Yes, yes.
What are you going to show now? Can we take 5 minutes interruption?
Okay.
And after that, you will show the sinus surgery, okay? Or
Recording of
okay,
I can show you sinus recording if majority of the people are wanting sinus recording to see.
okay, sure. But 5 minutes interruption because we have
Okay.
to something important.
Okay, let's wait for 5 minutes.
You take rest 5 to 10 minutes.
Okay, I'll get back to you in 5 minutes. Okay.
So, while the observing people,
Hmm. Bro.
you know the observer is the major scientific partner of our this workshop, and I like to invite Mr. Ashfaqur Rahman to show us something regarding observance. But it will be very sharp, precise, and clean, I hope.
Honorable Doctor, thank you very much. Good afternoon. I am Ashfaqur Rahman on behalf of Oxford Pharma. And first of all, I would like to present my heartfelt gratitude to you for being the major role in this program as a major scientific partner. And now I'm going to show my our company most famous brand that leads all over the Bangladesh. Okay, so dear Honorable Doctor, you know the old is gold as always, and Oxford Pharma has been introduced into the Bangladesh pharma market at 1956. At that time, only 2 or 3 local companies is concurrently producing their pharmaceutical product in our country. And on that day from till now, Oxford Pharma is the most leading, progressive, and modern pharmaceutical company by your continuous support. And thanks from the bottom of our heart. So this is the greatness of this company, and this great stand that belongs to the Polishal, just the bank, the river of Rupatoli. And Honorable Doctor, I would like to let you know that this is the fourth largest pharmaceutical company in all over the Southeast Asia. And doctors, you know that great always invite the greater, and in this great pharmaceutical manufacturing technology, we are introducing some of the some renowned countries in all over the Europe, such as Germany, Holland, France, and some ultimate great granulation machine, especially from as well as blistering machine from Romaco Sibler, Romaco Macoper, and also the other of the country belongs to Italy. So now I'm going to enter into the clinical arena. That as you know, doctors, that asthma and allergic rhinitis and liquid receptor, the liquid mediator is always the main culprit. And this liquid receptor is always responsible for smooth muscle contractions by maneuvering the major 3 receptors, that is LC, T4, T4, and E4, as you know, doctors better than me. And this receptor is always blocked by Montelukast. This is the major role player. And we have the Montelukast brand, that is our brand name is Trilock, Trilock, Trilock. And this our Montelukast brand Trilock is US DMF grade Montelukast grade raw material we are using. And this US DMF grade raw material that always the symbol of excellence, as you know, doctor, and that ensures the purity, safety, and efficacy. And along with the our DMF grade raw material, and we are also the first time introducer in our country that Montelukast first time in our country that Montelukast soft chewable technology, and our brand name is Trilock 10 milligram CT, Trilock 10 CT. That always ensures the easy to take, quickest onset, and the best for pregnant and geriatric patients, and also the no risk of choking and low water record as well. And Montelukast that some sort of clinical significance, as you know, doctor, that Montelukast thinks that our Trilock significantly improves the daytime and the nighttime asthma symptoms by improving the 87% and 89%. That ensures the improved patient quality of life. And this is our widest range of Montelukast brand, that is our Trilock. All the dosage forms we have, all the mother brand belongs. That there is all the dosage forms our Trilock brand has in one. And another brand is the Candivac, the preparation of beclomethasone, cortimazole, lidocaine, and beclomethasone. And this is always the formidable combination for any sort of care infection. That's our brand is Candivac. And as you know, doctor, that we are the king of the nasal spray formulation in Bangladesh, as by introducing the CPS, the cartridge pump system device, and our brand is Gelda, is the frequently prescribed by your hand, This is the first time in Bangladesh in CPS device technology. Our brand name is Delta, the preparation of epilastic and fluticapsule propenoid. And there's a mega brand of our company that is Phoenix, the key of all TPI, the preparation of rabbit plasol. That our brand name is Phoenix, and this is a renowned brand among you. And also, nowadays the most frequent prescribing antibiotic, the preparation of cefuroxime and clavulanic acid. Then our brand name is Clavusef, CLAVUSCF, and all the doses from we have. And that's all about my presentation. Thank you for giving us the opportunity for another time, for your valuable time. On behalf of Twilo, Phoenix, Candidate, Clavusef, and Jelda. Thank you very much. Thanks, Mr. Ashfaq. Thanks to Obsolin for giving us tremendous support. That team is always with us. Thanks again. Now, the Satish Jain will show the sinus surgery and others. And our official photograph we will take at 2, large and official photograph at 2. And after that, we will go to slight change of our program. That is, we are scheduled to go to Ratarpur, but it is submerged now, underwater, totally submerged. So we have changed our plan, and instead we are going to a safe place, that is Shadapathor again. Okay. Yeah, and another big team will join us. Mahmoud, Dr. Jakaria, Dr. Machu, and Dr. Supuki. They are coming soon to our house, and all we will go together to the Shadapathor after class. But don't forget to have a picture with all at 2, sharply at 2. Okay. Thank you, sir. পরে এই হ্যালো কানেক্ট করো স্যার আমরা কয়টা রওনা দিব স্যার আমরা কতটা আড়াইটা থ্যাংক ইউ Devashish, correct. I request audiovisual people to do it fast.
তারপরে যাবে
কি হবে কানেকশন তো করছে হ্যাঁ সতীশ হ্যালো communication
Yeah. Evening. Control microphone here. Yes. Lot of negotiation. TBS.
মাইক্রোফোনটা করেন
Hello.
Hello, Satish. Hello.
Hello, sir. Am I audible?
Yeah, you are audible, and Professor Ashraf sir and Professor Yusuf Fakir, Professor Khurshid Mazumdar, and Professor Delwar Hussain, our Secretary General of ORNSP, Bangladesh, and Professor Tushar. All are here. Professor Malik Afroz, uh, Arkenath sir, and many other people are here. House is full. So you can start your session.
Thank you. So nice of you. So once again, my regards to everybody. And thank you once again for bearing with me, I would say here. I'm again apologizing for not able to make for the Bangladesh, for the reasons I told you. In spite of the best try, we couldn't make it. So next is, as we discussed, I'm going to take you through, you connect. Functional endoscopic sinus surgery. For next 1 hour or so. This surgery nowadays is aimed to tackle the inflammatory disease of the paranasal sinuses, which is mostly steroid dependent, which is not able to be tackled by the maximal medical treatment, which consists of mostly topical topical nasal sprays, saline wash, and short course of antibiotic and steroids. In spite of that, if the symptoms are problematic, then you have to take up for the sinus surgery for the regions. And nowadays, the target for sinus surgery is not only for the disease removal, but to give wide openings for the future introduction of topical steroids to prevent disease coming back. So this case, I'm going to show you to take you through important steps of the sinus surgery in this particular case. Why sinus surgery, discussion is so important? Because the sinonasal anatomy is so variable. The close proximity to the critical structure, skull base, orbit, carotid artery, optic nerve, sometimes makes the possibility of complications, make the surgeon nervous, avoiding going close to these structures, and all this fear can be shattered with a good CT scan, understanding good CT scan. And nowadays we prefer, using on the DICOM format, three-dimensionally in a dynamic format. So you get to know three-dimensional anatomy of the region where we are operating. I will quickly take you through this patient. This patient is looking like frontal sinus. Interesting anatomy. That's why frontal sinus at this level. When you see the beginning of the maxillary sinus into the picture. Use frontal sinuses. See the next picture. Look at the. Can you focus here? Floor of the frontal sinus. Making the frontal sinuses above. The pneumatization on both sides above the orbit, looking like frontal sinus. As you go behind frontal sinus at this level, when you see the beginning of the maxillary sinus, narrowing the frontal sinus outflow. When you see the beginning of the cribriform plate, is roughly a centimeter behind. Frontal. This is very important anatomy as you are working sometimes between the frontal sinus and the frontal recess. See this pneumatization going above the orbit is not frontal sinus. Looks like frontal sinus. Hello?
Please off your recording sound. Please turn off your recording sound. Both sounds are mixing and we cannot hear anything.
Pardon. Can you repeat?
Hello, sir. Let me tell you, sir. The sound from your video and the things that you're saying right now, they are overlapping.
Okay, so let me silent that.
Okay, yeah, that's what I was trying to say.
Oh, I'm sorry. I should have done before. So now see, it looks like frontal sinus, which is actually not the frontal sinus. We are far behind. We have been, seeing the glimpse of the maxillary sinus coming into the picture. We can see the cribriform plate in the picture, which is far behind the frontal sinus. Earlier was the frontal sinus, but here it is not. And this is the frontal recess, which is pneumatized above the orbit, which is known as supraorbital cell. See the huge supraorbital pneumatization. We had seen type 3 cell in this patient. We have seen a small osteoma. We are seeing this supraorbital pneumatization, complete opacification of the ethmoids, complete opacification of the ethmoidal cells, all the way, cribriform plate with a good configuration, not very deep cribriform. See, these are important catch points. Important points need to be taken into consideration. This is the level of the ethmoidal artery, anterethmoidal artery. See the beaking of the orbit here. Beaking of the orbit leading to the anterethmoidal artery, which travels the roof of the ethmoid to pierce the lateral lamella of the cribriform plate. And see, here it is the pneumatization above the level of the artery. That means the artery is very, very prominent in this particular situation. And it is posterior to the frontal sinus, posterior to the frontal recess. And now at the level of the cribriform ethmoidal roof, you see this artery passing through the roof into the cribriform lateral lamella. So these are important areas, need to be checked on CT scan as you go behind the thick postethmoidal roof. Now you see the orbital cavity getting narrow and narrower. And in this particular patient, you see the pansinusitis disease involving almost all paranasal sinuses with more, on the left side, this lateral recess of the sphenoid, on the right side as well, with some opacification. So this is a sort of pansinusitis, which I'm going to take you to the surgical step. Surgical steps of sinus surgery are important to understand to prevent complications. This is the surgery of landmarks. You have to identify landmarks at every point of time so that you can avoid complications. Number two, in order to identify the landmarks, you should have a good surgical field. And good surgical field is achieved not only by intraoperative preparation, but the preoperative preparation as well, by means of giving topical steroid, oral steroids to reduce the inflammation, mucosal edema, vasodilatation and all that. Ultimately, overall, less bleeding, and intraoperatively by means of decongestion of the areas. And we use marrow cell packs to decongest. Yes. See this. Preparation is very, very important using the marrow cell packs. These marrow cell packs we soak in saline and adrenaline. Depending on the age of the patient, you can, make the solution accordingly. In elderly patient, we should avoid using very, very strong adrenaline. But yes, in younger, you can use even pure topical adrenaline, 1:1000, and it is only topical, not injectable, not infiltration. It is pure topical only, not infiltration. So even the single application of the topical adrenaline decongests the entire mucosa to prevent its systemic absorption. That way it is pretty safe. So many studies have been done now, which have shown to be this topical adrenaline to be very, very safe, and we have used in our thousands of patients where this topical adrenaline being pretty safe. Now, looking at the sinonasal anatomy after the decongestion, feel free to interrupt me any point of time. This is the middle turbinate. This is the middle meatus where you can see the polyp coming out. This middle turbinate is attached superiorly, anteriorly to the lateral nasal wall, and posteriorly it goes about to get attached onto the cribriform plate at the junction of medial and lateral lamella. So this is the vertical portion of the middle turbinate, which is very, very important. The first part of the middle turbinate, which is vertical, it is very, very important. And that is attached to the lateral nasal wall here. There is the polyp coming out of the middle meatus. Sometimes this polyp distorts the anatomy of the middle meatus. because what you need to identify at this point of time in the middle meatus, the first structure we deal with in the sinus surgery is the uncinate process. So the uncinate process should be identified at the beginning, and then it is resected very carefully. The reason being, the uncinate has a two portions, one vertical and the second one is the horizontal one. The vertical portion gets attached above to the lateral nasal wall most of the time. Most of the time to the cribriform plate, giving a median drainage to the frontal recess or the frontal drainage pathway. Sometimes it can be attached medially onto the, middle meatus or the middle turbinate or the skull base, and then you can pick up by the CT scan and stay careful. This, this, this uncinate is a very, very useful anatomy. This is important to remove in the beginning to enter into the maxillary sinus. And this identification of the uncinate sometimes is made difficult by polyposis, which makes the uncinate process distorted. But still you can identify it as the only mobile structure in the lateral nasal wall, entire lateral nasal wall. What you see, this punch out defect, this punch out, this kind of a two-dimensional defect cannot be natural ostium. This is accessory ostium or fontanelle, where you can see two mucosal layers on either side with no bone in between. And this cannot be a natural ostium. Natural ostium is always hidden by the uncinate process into the infundibulum. So don't get confused with this as a natural ostium. This is this is a punch out defect. This is accessory ostium. Just a moment. Wait for me. Just a moment.
Hello.
Yes. So this is about the identification of structures in the beginning. I can skip all this. Now the first step in this surgery, see this repeated decongestion, decongestion, decongestion. The first step in this surgery is the uncinate process removal. See, this uncinate is two parts. The upper one is the vertical, lower one is the horizontal. Earlier, this uncinate would be removed by means of using a sickle knife all along its attachment onto the lateral wall, and you can remove in toto. The only issue is this uncinate sometimes is very close to the orbit. And when you try to remove using sharp instrument sickle knife, you can get an accidental entry into the orbit at the beginning of the surgery, which is detrimental to the surgeon's temperament. So this is something which is never advisable. Nowadays, what we use a reverse biting. See this, reverse biting forceps at the junction of upper vertical and horizontal. Introduce your reverse biting and bite through the uncinate. See this, bite through the uncinate. Introduce your reverse biting like this. Engage this into this region and then bite through one by one, progressing anteriorly. Just tilt it little down to stay away from the nasolacrimal duct superiorly. See this, bite through, keep coming anteriorly until you reach the hard bone. That is very, very important. Keep going again until you reach the hard bone, and that hard bone is the nasolacrimal duct. The moment you feel the hard bone, you are not supposed to bite through it. Otherwise, you can end up giving a nasolacrimal, duct injury. Now, see what you have opened. This three-dimensional space lateral to this uncinate. This three-dimensional space is the infundibulum, and in the lateral part of the infundibulum is the maxillary sinus ostium, which opens. So what we have done basically, when we have bitten through this uncinate, is the infundibulotomy. What we have done is infundibulotomy. This is the upper part of the uncinate, and this is the lower horizontal part of the uncinate, which goes, posteriorly along, ultimately ending up in the inferior turbinate or going up to the perpendicular plate of the palatine bone. So this is very, very important step. At this step, see this. This is the lower part of the uncinate. Now I am fracturing the lower part of the uncinate. See this? This is your ball probe. You introduce into the opening, which we made in the infundibulum, and then fracture the lower part of the uncinate. See this? Fracture the lower part of the uncinate. This is removing. Oh, I have gone ahead. Yeah. See, after fracturing, you can use the micro debrider to remove the lower part of the uncinate to create a middle meatal enterostomy. See, this is the upper part of the uncinate which is intact. What we are doing is removing the lower part, and this is the maxillary sinus ostium. This is maxillary sinus ostium. This is complete removal of the lower part of the uncinate. You can use a through biting forceps, or you can use a micro debrider, this shaver here, to take away this lower part of the uncinate. This creation of middle meatal enterostomy, the size of the middle meatal enterostomy, the desired size, depends upon the pathology behind. In massive fungal diseases which require long-term surveillance, which require more introduction of steroids, long-term topical steroid, you can create a mega middle meatal enterostomy. Mega middle meatal enterostomy means what I have done is a type 1 or 2, you can say, middle meatal enterostomy, not going to the limits all around. See this, not going to the limits all around. If I happen to remove this posterior wall, see this, if I remove this posterior wall more behind till flushing with the posterior wall of the maxillary sinus, this part of the medial wall which is here, if I remove it completely till flushing the posterior wall, this is type 3 middle meatal enterostomy. More you can introduce the steroid, more you can follow, more it is unlikely to stenose. And if you really want more drainage, more even gravitational drainage, you can remove this part of the inferior turbinate and flush it to the floor of the nasal cavity, a sort of type 4 middle meatal enterostomy. So depending upon the need, depending upon the pathology, sometimes you deal with the tumors and so many other indications you can, or like odontogenic cyst and other things, you can flush it for the long-term surveillance and other things. So in this case, it is not required anymore. So this middle meatal enterostomy dimension all depends upon, for the indication what you are doing. Number 2, after this, see this is creation of the middle meatal enterostomy. At every point of time, you need to keep optimizing the field using your marrow cell again and again. I told you this is the surgery of landmarks. From initial few landmarks like middle turbinate, like uncinate process, creating uncinotomy, infundibulotomy, we have been able to achieve this middle meatal enterostomy. This is the first step in the surgery. Again, decongest the field, and then we can go ahead with the next step of surgery. Irrigation. Again, repeated irrigation is one thing which can, achieve good surgical field. It promotes hemostasis as well as wash out all inflammatory mediators, secretions, and all those which are responsible for overall inflammation. So this is middle meatal antrostomy. Now, coming to the next step. See this. This is middle meatal antrostomy below. This is the upper part of the uncinate process. This upper part of the uncinate process is very close to the orbit, medial wall of the orbit. So next step is removal of the upper part of the uncinate. You can remove it by the microdebrider. You can remove it with a through biting. The safest way is to fracture. See this. Use this curved curate, push it behind the uncinate and fracture it anteriorly. That is a very safe step away from the critical structures behind, away from the skull base and everything. You can go behind and fracture it anteriorly. That is a very, very safe move. See this, go behind and fracture it anteriorly. That is the uncinate. This way you don't traumatize, don't give problem to the any structure behind, and you can safely now debride it to get rid of it. So this removal of the upper part of the uncinate is again very tricky, very important. So the safest way is go behind. See the bony uncinate, you can remove separately. You can remove the bony plate separately, and then you can debride the soft part of the uncinate.
Dr. Satish,
Yes, please.
Dr. Delwar speaking.
Yes,
If
please.
there is any pathology in the other area, only the maxillary sinus, then
Yeah.
upper part of the exoskeleton you have to remove or not?
Not really. For isolated maxillary sinusitis, sometimes we do, like for odontogenic sinusitis or other, isolated maxillary lesions.
Yes.
Actually, you don't need to disturb the face, frontal recess outflow. You are not supposed to remove the upper part of the uncinate unless it is involved by the pathology.
Yes.
So for sole maxillary sinus disease, you can avoid removing that. But the indications are very limited. As I told you, most often it is for the odontogenic sinusitis involving the maxillary sinus. Now, see this upper part of the uncinate being cleaned off, being debrided using the red 40 debrider and flushing with the lateral wall. That's a very, very safe move, you can say, at this point of view. Yes, see now, the upper part of the uncinate being debrided after being fractured. And this has to be done under vision as it is very, very close to the orbit laterally. See, this is your middle meatal antrostomy. This is your bulla ethmoidalis.
Yeah.
This is part of the uncinate, the bony uncinate being removed separately. The bony plate and the rest you can debride easily. This is your middle turbinate, which needs more and more respect. Hello. This needs more and more respect. The middle turbinate deserves respect, and we are not supposed to do anything to the middle turbinate. Don't disturb it, which is the best treatment to the middle turbinate. Because if you dismantle this or make it floppy, it can fall back, closing the lateral wall axis. So it has to be respected. Above, if you try to manipulate too much above, this can lead to problems like, even if the CSF leak, if you try to dismantle it from above. So the middle turbinate need to be respected.
Sometimes there is a combo bullosa in the middle turbinate.
Pardon?
Combo bullosa.
Yeah, if there is a concha bullosa,
Yes.
if there is a concha bullosa becomes an obstruction to the, access to the lateral wall. And in that situation, we should incise the concha and remove the lateral part of the concha to open up the space without disturbing the medial part and the integrity.
Yes.
Now see, once this upper part of the uncinate being removed, lot of, structures coming into the picture behind all these cells. This is the beak. It should be completely cleaned until the beak. Open up the beak area more and more to go up for the frontal later. Our technique is to do the frontal sinus work at this stage, keeping the bulla ethmodalis intact. See, the bulla is lower down, it is intact, and this is all the ethmoidal cells. The bulla is here, lower down. That's the medial orbital wall after removal of the upper part of the uncinate and few of these ethmoidal cells. That's the bulla. And because of the massive polyposis, many a times this bulla gets more and more atrophied, more and more compressed, I would say, rather than being a very big bulla. So this is the picture of after repeated irrigations, marrow cell packing, under vision clearance, and see what we have achieved so far is the middle meatal antrostomy and removal of the upper part of the uncinate. Now the next step would be to go to the frontal. The frontal sinus is a very, very key sinus, challenging sinus for the surgeons for many reasons. See this repeated marrow cells, and here we use and change to 70 degree to look up, to follow the intact bulla technique, which was initially propagated all over by our own Dr. D.S. Sethi from Singapore. For the regions, see this bulla goes up to the skull base. And as it goes to the skull base, it covers the anterethmoidal artery. Now I am with the 70 degree. See this up. The bulla is lower down, and with this 70 degree, you can see the structures above the bulla, the beak and the structures underneath the beak. All these are very, very important to see with the 70 degree. 70 degree will give you a panoramic view of this region. Why we want to keep the bulla intact? As long as bulla is intact, it covers the anterethmoidal artery at the level of the skull base. As it goes to the skull base, the bulla gets attached to the skull base. It covers the anterethmoidal artery from anteriorly and protects the artery getting damaged by the surgeon. So in those situations, the intact bulla technique is the key. Intact bulla technique is the key. See now, this is middle turbinate. I am going close to the middle turbinate. This is the Agarnese cell. See this huge Agarnese cell. I am going in between the Agarnese and the middle turbinate. See this? To get into the frontal recess, this is a huge Agarnese cell. And this is sitting on the face of the frontal sinus outflow. This huge is the Agarnese cell. In order to get into the frontal sinus, we need to go behind and up this Agarnese. In order to go behind and up, see this, the space between the Agarnese and the middle turbinate. This is middle turbinate, this is Agarnese, and the space between these two will lead to the frontal outflow. See this, the bigger the Agarnese, more the space is narrow, and more these patients are predisposed to frontal sinusitis by means of mechanical blockage to the frontal sinus outflow. See this? How this cell is completely covering the frontal recess region.
That is why you told that any cell,
Pardon?
any cell remain in between the medial wall and the lateral wall, you have to remove.
Yes. So you have to have a guide.
Yeah.
If you are lost, see the beauty of this 70 degrees, my both medial and lateral limits are in view.
Yeah.
How come? My lateral limit is this medial wall of the orbit is in view. My medial limit, this turbinate is in view.
Yes.
My posterior limit, this bulla is in view.
Yeah.
So I can work freely in between the limits. I can ensure not crossing my limits. If suppose I don't follow this medial limit and go too medial, I can easily damage the skull base.
Yeah.
Get a CSF leak. So 70 degree gives you visualization, show you limit. That's the beauty of the 70 degree, so that you don't cross your limits and get into the right areas. And see this. That is what now I am doing. I am going into the medial wall in between. See now, I am trying to fracture this, going behind and above this Agarnese cell, fracturing this Agarnese cell to get into the frontal sinus. Fracture. Fracture carefully, get into this. Decongest again and again, so that it gives you best visualization. Now see the area very clear. You
Yeah.
can get into it very clear now. The ball probe is the tool. All the limits, lateral limit, medial limit, posterior limit, this bulla, and this is your whole agarneji. Now you go medial to the agarneji and behind it. Can you see this? Through the bone. See the thin lamella of the agarneji. You can go behind and superior to it and fracture it laterally and anteriorly. Go behind and fracture it anteriorly. See this? In order to get into the frontal recess. See carefully, the direction of the instrument should be superior, anterolateral. In any given situation, if your instrument is medially directed, it can lead to problems. See this? Instrument direction should be medial. Fracture this agarneji. पीछे पीछे तो फिर लाने पड़ेगा ना, वो नहीं करेगा। ना बात कर बंद करेगा बात करा दो। See this, sorry. See this? We remove this lamella and reach into the area of the frontal outflow. This is very interesting. See this area of the frontal outflow? Is it visible?
Yes.
So, it looks like frontal sinus. What do you say? It looks like frontal sinus, but where the frontal sinus is? I told you on CT scan there are various cells. Supraorbital cells, type 3 cell. See, this is the type 3 cell above. Can you see this? If you are not aware through the CT scan, one can presume this to be
Frontal sinus.
चलो वो पीछे स्किन लगा दे. See this? This looks like frontal sinus. Can you see?
Yeah.
There are so many openings which can confuse you. That's why I picked up this case for you. CT scan is the key which tells you which cell is medial, which cell is lateral, which cell is going up to obliterate the frontal sinus drainage. Now see one by one. Which is frontal sinus, which is which cell? See this? I am going behind this cell. I told you this is the cell. See, this is type 3 cell.
Yeah.
And the frontal sinus is medial to it. Let me go back. Yes. Hello. Now see, this is the cell. This is the wall of the type 3 cell. It looks like frontal sinus. This is not frontal sinus. Frontal sinus is behind. Can you see that?
Yeah.
So type 3 cells are lateral and narrow the frontal sinus drainage from laterally. And this is how this is narrowing the frontal sinus drainage pathway. The frontal sinus is displaced medially. So if this cell wall is removed, you can widen the frontal axis. So this is the, see carefully.
It is easy way to follow the beak.
Yeah. You follow the beak When you
Usually you can go to the sinus
yeah. When you follow the beak between the lateral and medial wall,
Yeah, yeah.
close to the beak, that will lead to frontal sinus.
Yes.
In case of huge type 3 cell, it can confuse you. So the difference between cell and the sinus is the cell wall is always thinner.
Yes.
Cell wall is transparent. You can see through it, but not the sinus wall. See the two openings? The medial wall is the sinus one, and the lateral one is the type 3 cell. Can you
Yes.
see?
Yeah, yeah.
Will go behind this cell and fracture it out completely. The lateral one is the type 3 cell. That is the type 3 cell, and this is the frontal sinus. So we will go behind this cell wall, party wall between the type 3 cell and the frontal sinus. Go behind and fracture it out. Sometimes it is going up too high into the frontal sinus, which may require frontal sinus drill out. Otherwise, you can remove it from here only. See this? This is your type 3 cell. This is frontal sinus, and this is the osteoma here. So what you need to do is go behind this cell. See this? Go behind this cell, remove this party wall and widen the frontal sinus. Can you see now?
Yeah.
So this is frontal sinus. This was the party wall, which is fractured and need to be removed. So what you need to do is remove this party wall. See, this is the party wall. Can you see again?
Yeah, yeah.
Remove this and widen the frontal sinus drainage. That's the septation. That is the cell. And this is how CT scan is useful. 70 degrees useful. You can remove that party wall, widen it to give a good frontal sinus outflow. See the beak anteriorly, which is the anterior limit. You cannot go beyond that. So this is the party wall. That is the cell which need to be completely, fractured. That is very important. You can remove this. See this septation can be removed by means of a giraffe forceps, horizontally opening giraffe forceps. That's the cell. Rest can be debrided. See that? Rest can be debrided and this area can be widened. See this? It can be widened. See more cell wall coming. You can remove it again and widen it. See this more cell wall coming. So idea is identify on CT scan and accordingly execute your plans so as to accomplish the comprehensive work.
Intersinus septal cell. It also.
Pardon?
Intersinus septal cell.
Yeah, this is type 3 cell.
Yeah.
So the cell wall, the party wall being removed and the frontal sinus opening is being widened more and more. See this? Now the frontal sinus opening so big. Now we saw there was a supraorbital cell which further narrows from laterally. We have to deal with that as well. So many cells in the same patient complicating the frontal sinus outflow. But once we remove all these cells, you will see finally how big the frontal sinus outflow can be to prevent restenosis or repeated issues, repeated symptomatology and the problem again and again. So that in order to remove that, see this all cell wall being removed and the frontal sinus being widened more and more. See that?
Yeah.
That is the cell wall there is still there. And this is the osteoma. This is the osteoma which is also contributing a little bit to the frontal sinus blockage. So all these septations, we should be able to differentiate these septations on the basis of the radiology, on the basis of the feel and the look. We should be able to differentiate septations and the cells from the sinuses. And once they are displaced, fractured, we should be able to remove them. See now, as we go posteriorly, this posteriorly is a different cell. This is cell posteriorly. Anteriorly, the frontal sinus. And this posterior cell leading laterally above and above the orbit is going to be the supraorbital cell. If we don't remove the party wall or the frontal sinus with the supraorbital cell, the frontal sinus opening remains narrowed by this cell. So in order to do optimal work, we need to remove the party wall between this cell and the frontal sinus outflow. Again, see how much the frontal sinus being widened. You have to widen it more and more. See, so many openings now coming into the shape. The frontal sinus, the most medial one, being in picture, the type 3 and the supraorbital cell being lateral, all narrowing the frontal sinus outflow, complicating the frontal sinus anatomy. This is the beak. Beak is the anteriormost anatomy, that's the anteriormost limit. The frontal sinus is medially here, and this cell is the supraorbital cell. See this, again the more and more party wall being removed. This is the party wall. The more and more party wall being removed, we have ultimately goal to make this one opening from supraorbital to the frontal sinus, removing all these party walls. So never get confused with all these cells, assuming frontal sinus. Sinus is different, cells are different. We should be able to differentiate from CT scan. You should get used to differentiate between cells and the party walls from look. All these are important.
If the beak is a larger one, then you can drill this area, beak area.
Yes. If the big beak is obstruction, narrowing, cell is going up, we should not think about twice before drilling this beak. So that beak should be drilled. Now see this posterior cell being opened up. This is, see this. This is your frontal sinus, and this cell being widened is the supraorbital cell. See, being the way we are using the reverse blade or the microdebrider, which is known as adenoid blade. I showed you in last case we never use. We condemn it for using for adenoids because it is a rear facing blade. See now how big the frontal sinus is?
Yes.
After removing that party wall, still that party wall is remaining, and see the frontal sinus being widened. More and more, it should be widened. This entire cell wall being removed. See now?
Yes.
Widen it. This is very important to give adequate frontal sinus drainage, adequate and optimum. Now, earlier, people would measure it. See now this frontal sinus. Earlier, people would measure the final frontal sinus, ostium size, like should be more than centimeter, should be more than 1.5 centimeter, whatever. It cannot be taken like this. We should be able to flush to the limits whatsoever the final size is. It may be more than 2 centimeter, it may be less than 1 centimeter according to the anatomy of that particular patient. See this? The frontal sinus drainage pathway with 70 degrees, this is the beak, this is middle terminate laterally, and more party wall coming out to widen the frontal sinus drainage pathway. So, we cannot measure in centimeter, we should continue until we remove all septations to flush the frontal sinus, completely to its limits. If you leave the septations, the mucosa can grow along and can re-stenose. If you flush to the limits, the re-stenosis can be more efficiently prevented. Now see, So this is complete type 3 cell removal. Now we will go behind and, remove the party wall with the supraorbital cell, remove this osteoma as well, and give a final shape to the frontal sinus outflow. The biggest possible. The rule should be biggest possible, not to be measured in centimeter or millimeters. Every frontal sinus anatomy is different, and the goal is to flush it with the limits. That should be the goal. See this, using 120 debrider and flush to the limits. Flush ultimately to the limits, which is the goal. See, the biggest possible frontal sinus drainage pathway we are supposed to achieve. See the frontal sinus all around. The opening is mucosalized. That's very important. We should avoid leaving raw areas. If you leave too many raw areas, again the fibrosis can take place, restenosis, neosteogenesis, and all those are difficult issues which are much more difficult to manage than the primary pathology. So under vision, 70 degree, using sharp instruments, using micro debrider, all are important to prevent, demucosalization. Whatever instrument we use should cut sharp to avoid mucosal peeling. We should not peel off the mucosa to prevent future issues. So still we are in the frontal sinus work. Still more frontal sinus work is required to be done. See, the bulla is intact still. The beauty is, as long as bulla is intact, we are not bothered about the anterethmoidal artery. This bulla is going to the skull base there, anterethmoidal artery is behind. So intact bulla technique offers you the opportunity to protect your anterethmoidal artery getting unnecessarily damaged by the surgeon. See that? That's the panoramic picture of the frontal sinus. Now what I am doing, see this is your supraorbital cell. Supraorbital cell, and this party wall being removed to widen this and communicate with the frontal sinus all the way. Decongestion. Now with the 70 degree. See now the reverse blade. Reverse blade will ensure, see this is, we call it as a skull base blade. As with 70 degree, it becomes front facing blade. See this, you can clear your skull base. Flush your skull base with the reverse blade. And once you use reverse, with 70 degree, it becomes, the cutting edges come into your view. See the cutting edges. The important principle of micro debrider is to keep the cutting edges under vision. With this 70 degree, you can keep your cutting edges under vision. See now, the skull, these are the cells along the skull base. The skull base is deeper, and we are opening all these cells with reverse blade to open up the skull base. See this? All these cells getting opened, and this is your supraorbital cell. Can you see very clear now?
Yeah.
And see the party wall. That's the party wall between the frontal sinus and supraorbital cell. If I remove this party wall completely, my frontal sinus outflow will be much, much bigger, and the supraorbital cell will join the frontal sinus to give a wide opening. See this party wall being removed. This party wall can be completely removed. See this? Can be completely removed. This party wall has to go. This is supraorbital cell. This is osteoma. See this party wall being removed. See the septation being removed between the frontal sinus and this large supraorbital cell with deep recess. entire party wall being removed with the micro debrider, becoming one cavity. Supraorbital and the frontal sinus becoming one cavity. See now the osteoma is dislodged as you remove this septation and will come out. So far, the bulla is intact and we are not bothered about the anterothoracic artery. See this septation being removed between the supraorbital cell and the frontal sinus. See this supraorbital, deep supraorbital recess? And this is the party wall. Once we remove the party wall completely, you can imagine how big is going to be the frontal sinus drainage here. This is such an interesting frontal sinus. You have seen big agarneji, you have seen big type 3, you have seen supraorbital cell, supraorbital recess, and an osteoma on that. So completely, narrowing all these things together, frontal recess. And by following with a 70-degree and keeping your landmarks in view, landmarks means your turbinate. In any given situation, your turbinate is in view and we are not supposed to cross medial to the turbinate to damage the skull base. In any given situation, your lateral wall is in view. The orbital wall is in view. See this? And in any given situation, we are not supposed to breach that to get entry into the orbit unnecessarily and give
up to our very honorable guest today, EMA very committee member and newly elected Vice President of Adivasis State is very much here with us. We will give a big hand for him. And also, Professor Jalal Mahmood, are you there? Jalal Mahmood, who has served in our medical college, in Sinusitis Medical College, he is with us. So we are very thankful to all of them to come here, having a lot of faith. Thank you very much.
See now, the big frontal sinus drainage pathway. Now see, this is the frontal sinus, this is the party wall between this is supraorbital recess and this party wall being more and more removed to widen this axis, and this is the osteoma which is getting dislodged. And see finally how the frontal sinus outflow getting bigger and bigger. So the frontal sinus requires a very, very dedicated approach, very systematic approach with three-dimensional understanding of the CT scan to avoid complication, because the complications in the frontal sinus, the margin of safety is very less. This is the osteoma which is coming out. The margin of safety to the complications, to the skull base injury, to the orbital injury, to anterothoracic artery injury, all these are not uncommon if you deviate from your principles, as the margin of safety is very less. And see this, more and more. See now, to begin with, how hidden was the frontal sinus drainage pathway. There were multiple openings. Yes, sir.
If there is the ostomy attached to the skull base, what is your approach in this case?
Pardon?
This osteoma, if it is attached to the skull base.
Osteoma?
Yeah.
Yeah, the same way. See, you have to expose all around. Sometimes it is big. You have to, dismantle it by means of breaking it into small pieces and then finally removing the attachment. Almost always you can get away with the osteomas endoscopically. Bigger one, wider attachment, you may have to, cut into pieces by means of micro drill or something, and then finally removing. The more you make it smaller, easier it is to dismantle it from the attachment. See now how big the drainage pathway is. It is in centimeters. See now the big frontal sinus opening. All cells taken care of. See the limits. Beak anteriorly, turbinate medially, the orbital wall laterally, and all septations in between removed one by one in a sequential manner to widen the frontal sinuses. Yet your anterethmoidal artery is nowhere in the scene. It is behind. And what it is, who is protecting the anterethmoidal artery? The bulla. So that's the beauty of the intact bulla technique, that as long as bulla is intact and reaching the skull base, your anterethmoidal artery is always protected by the bulla. Because bulla goes anterior to the anterethmoidal artery course to attach onto the skull base. With 70-degree, keeping everything anteriorly focused, you are automatically away from the anterethmoidal artery trajectory. Anterethmoidal artery crosses the anterethmoidal roof in the most posterior most part of the anterethmoid roof. After the course of the anterethmoidal artery, it is the beginning of the posterior roof. It doesn't course in the anterior part of the roof of the anterethmoid. It courses to the posterior part of the roof of the anterethmoid. While walking at the frontal sinus anteriorly with a 70-degree, you are automatically away from the anterethmoidal artery course. Got my point? So having done this, the next would be to remove the bulla. This is the biggest opening you can think of. See this?
Yes.
Biggest opening. This is bulla now. So now you have to fracture the bulla. Again the same way. Go behind and fracture anteriorly, and you will see the anterethmoidal artery coursing behind. Can you see this? Below, behind and below.
Yes, yes.
So that is the course of the anterethmoidal artery and how the bulla was protecting it. That's the beauty. So in intact bulla technique, as long as you keep the bulla intact, your anterethmoidal artery is automatically protected. And that's one of the best way to protect this artery from getting injured by the surgeon. So you just dismantle the bulla, remove the bulla. Once you fracture it, it's a garbage. It's still with a 70-degree. See, this is middle meatal antrostomy, part of the inferior part of the bulla there. Osteoma, which was left below in the cavity. Now, coming to the bulla. So now using the microdebrider, you can remove this bulla once you have dismantled. See this? Completely and flush the anterethmoidal skull base. That's the bulla. The artery is behind that. Now once you have dismantled, hugging the bulla from behind, you have to fracture it anteriorly. Not hugging the skull base behind, hugging the posterior surface of the bulla. See the rest of the remnant of the bulla being removed with the microdebrider. This is the lower part of the bulla being removed. And see above at the level of the skull base once you remove this. you'll find the anterethmoidal artery coursing. See, this is the attachment of the bulla on the skull base. This is the attachment. And the artery is behind that attachment. That's how this bulla protects the artery from getting injured. So this is the attachment of the bulla. And see the artery behind. Can you see the artery here?
Yes.
Right in the depth at the level of the skull base. See, this is the artery. See this. See this. This is the artery going along the skull base obliquely. And this is the bulla attachment anterior to it. Artery here, anteriorly the bulla. So the bulla was coming from here to here, covering the artery.
Yes.
The moment you remove the bulla, the artery comes into your view, running along the skull base. See this. And this is the attachment of the bulla onto the skull base being removed now. This is being removed now. Once you remove, this is your artery, very, very clear.
Feel like in between the bone sometimes.
Pardon?
Artery lies in between the bone.
Leaving the bone.
Yeah.
Yeah, see, this was the septation projecting that has to be removed. Anyway, we are not supposed to disturb the bone over the artery. That is not our goal. So this is the anterethmoidal roof right from here to here, and that's the artery running along the roof. So the artery runs along the posterior part of the anterethmoidal roof, not the anterior one. So anteriorly, while working anteriorly, particularly anterior to the attachment of the bulla onto the skull base, it is pretty safe. See this septation I am removing with the skull base blade, same red 40 adenoid blade. And see, this is your artery. This is your artery here. So you can flush till the anterethmoidal artery. That is, and this is the posterior limit of your, see, this is your supraorbital recess. The posterior limit of the supraorbital recess is formed by the artery. Bigger the supraorbital recess, bigger the artery, the posterior the artery displaced. So that's the beauty.
Satish? Hello?
Yes, sir.
Dr. Mungal here. Yes, you will have more 20 to 25 minutes. And you will show sphenoid sinus and other things. Okay. So I like to request you to do a little bit pause.
Okay.
So we can see the sphenoid sinus and others.
Okay, I'll just finish off in next 5 minutes.
No. We are requesting you to continue in 20 to 25 minutes. Okay.
Okay, I'll be quick. No worries, sir. So now this is the end. What we have done so far is the maxillary sinus, frontal sinus, anterethmoidal skull base. This is the anterethmoidal artery. Now what is left behind? This is all done staying anterior to the ground lamella. What you see here, it is ground lamella. And all those cells now and the sinuses behind are the posterior group of sinuses. This is so far is the anterior face done. See my limits, the turbinate, the lateral wall, the maxillary sinus, the frontal sinus, the anterethmoidal artery. This is what so far is the anterior face done. Now we'll change to 0 degree. Now we change to 0 degree. And what we see here, this is your ground lamella. So all the sinuses left behind the ground lamella are posterior ethmoid and sphenoid sinus. So the most important sinus out of them is the sphenoid, and because there are important structures running through the sphenoid sinus in their posterolateral wall, the optic nerve, carotid artery. So entry into the sphenoid has to be very safe. One should not disorient, and that's what I'm showing here is the roof of the maxillary sinus. This is called as maxillary line. We call it maxillary line, the level of the roof of the maxillary sinus, which is a very important landmark. So now what I am showing quickly, in this is ground lamella. Behind the ground lamella is the posterior sinus, and behind that is the sphenoid sinus. So sometime one of the posterior cell grows beyond the sphenoid sinus, ONOD cell, and can disorient you from entering into the sphenoid sinus. So in that situation, what we do, we enter into the ground lamella medially. See this. Yeah, see this. We enter into the ground lamella medially, just medial entry into the ground lamella, and this maxillary line is the key. As you go medial, you will see the superior turbinate in this window. We made a window, medially we made a window into the ground lamella. I am not keen to do a post-sigmoidectomy first. I never know when I can accidentally enter into the sphenoid sinus. I should be able to know where exactly the opening of the sphenoid sinus is. So, stay medially. See, once you stay medially, you will be able to see the superior turbinate. That's the superior turbinate. See this? Once you see the superior turbinate, stay medial to it. See this? Once you see the superior turbinate, stay medial to it. See this? This is superior turbinate. Going more and more medially, this is superior turbinate. And see this, medial to this is the septum. So now I am between, this is superior turbinate, this is septum, and if I go in between them, it's going to be the sphenoid sinus ostium. See this? Remove the inferior part of the superior turbinate. Keep removing. This is septum. Then go flush along the septum, but not above the level of the maxillary line. That's the maxillary line here. So go along the septum, removing the superior turbinate, along the maxillary line, See this? More and more removing the superior turbinate, the inferior most part, and you will see the glimpse of the sphenoid sinus. That is the maxillary line. Never go above this line. You may enter into the roof of the sphenoid sinus because the roof is close to the sphenoid ostium. So never go above the maxillary line as a staying on the safer side. And this is going along the septum will take you right into the sphenoid sinus. Right into the sphenoid sinus. This is sphenoid sinus ostium. Can you see? Once you see the sphenoid sinus ostium, you can widen the ostium. Now we have the idea where the sphenoid sinus opening is, and we can accomplish staying anterior to the ostium. See, that's the ostium level. Now you can remove all these posterior cells staying anterior to the ostium. Staying anterior to the ostium will never encounter the optic nerve or carotid artery in any given extreme abnormal situation. The optic nerve and carotid artery cannot come anterior to the sphenoid ostium. Just you can quickly remove this posterior cells completely staying anterior to the sphenoid sinus ostium. That is the safest, safest point to prevent accidental entry or disorientation in the sphenoid sinus. See this, completing the posterior cell, ethmoidectomy, staying anterior to the sphenoid sinus ostium. That's the sphenoid sinus ostium. And then finally widening the sphenoid sinus. See the ostium. Staying anterior, you can remove anything. Widen the septations. Your optic nerve carotid artery cannot come anterior to the sphenoid sinus ostium. This is a very, very safe way of doing the post-sigmoidectomy. So post-sigmoidectomy is to be done after identifying the sphenoid sinus ostium and staying anterior to it. And then afterwards, you can widen the sphenoid sinus ostium under vision. This way you can definitely prevent damage to the optic nerve and carotid artery. You will never get disoriented that way. Never get disoriented. And now finally, this is widening of the sphenoid sinus ostium. This is the sphenoid sinus ostium, and we can remove this wall under vision as the carotid artery and optic nerve are going to encounter behind, and that too under vision. Now this ostium has to be widened. That's it to accomplish the sinus surgery. That is the last step. You know, this ostium so now my last step is widening this ostium. See this ostium being widened with a micro debrider. You can use the punch, you can use the sphenoid punch, you can use the micro drill, whatever, depending upon the thickness of the septa and how you are used to. Under vision now is the sphenoid sinus inside, and you can quickly widen this until the lateral wall, until the lateral. This is the Carrison punch. You can easily widen under vision. This is the party wall with the post-sigmoidal cell. You can widen under vision. So you are not supposed to do any sharp instrumentation inside the sphenoid sinus. See this? No sharp instrumentation inside. See, this is the interior of the sphenoid sinus, and that is widening, and this is all about the sinus surgery. This is full house sinus surgery on this side. Full house press on this side.
Okay. Thank you. For your time.
Thank you so much for your attention. I once again apologize for not making it to select. Thank you once again.
Satish,
Yes, sir.
you are very unsolicited and very much popular and a true friend of our community, our Indian community and Bangladesh. We are thankful to you for showing the nice and excellent demonstration for our people. I will talk to you after half an hour over telephone.
Okay, sir. Thank you. Thank you, sir.
Now we like to conclude with a gift hand to Satish Jain.
Oh,
Our dear participants, you are requested to take a picture together.
Sir, one
Oh, there is
Who's
a
in the
question from the audience. Anyone? Any question?
posterior
Hello, sir. So there is a question from our audience. Is that
yes.
can you show the location of both anterior ethmoidal artery and posterior ethmoidal artery so it's easier for us to recognize them when we are working in the skull base?
Yes. So anterethmoidal artery, you're valid because anterethmoidal artery runs through the thin anterethmoidal skull base, so it is prominent. With more cellularity, more disease eroding the bone, it becomes more prominent. Postethmoidal artery, since crosses the thick postethmoidal skull base, through the thickness, it is most of the time not very prominent. And yes, the disease can make it erode the skull base can make it prominent. There are many ways to identify the postethmoidal artery. People believe that it is 12 millimeter from the anterethmoidal artery behind, but that cannot be fixed. I told you, more the anterethmoidal skull base pneumatized, more the anterethmoidal artery pushed behind. The best way, what I believe in our clinical practice to identify postethmoidal artery location is 5 to 6 millimeter anterior to the optic nerve. Optic nerve is almost always visible. It's a prominent structure in the sphenoid. If you come 5 to 6 millimeter anterior to it, through the thickness of the skull base is going to be the anterethmoidal artery, posterior artery. And that is the most reliable landmark for the posterior artery, what we believe.
But that is kind of retrospective because when you are detecting from anterior to posterior, you are finding the optic nerve later when you are walking along the posterior. Posterior, most of the posterior ethmoid or working on the sides of the sphenoid sinus, only then we can find the optic nerve.
See, you are not supposed to positively identify the posterior artery always. Number one.
That's true, sir.
Number two, I showed you a technique of posterior. We first see the sphenoid ostium and then accomplish the posterior and then remove the party wall between the posterior and the sphenoid to uncover the optic nerve, and then you can follow anteriorly to look for the posterior artery. So technique is very simple in a sequential manner. You need not to bother about the posterior artery injury as it courses through the thick posterior skull base, unless the disease like fungus or something which is completely eroding the posterior skull base to make it prominent.
Another question, sir. So,
yes.
What would be the easiest tip for some young surgeons to find out where the anterior ethmoidal artery is, like to not injure it,
just to save the bulla.
To save the
bulla.
So the anterior, what would be the easiest tip to find out where the anterior ethmoidal artery is, so that we don't injure it during surgery?
I've already given you the catch point. The most important is the bulla ethmoidalis.
Okay.
Keep the bulla intact. Your artery courses behind the anterior attachment of the bulla onto the skull base.
Okay.
So you can perform your, anterethmoidal and the frontal sinus work without bothering about the anterethmoidal artery. And once you fracture the bulla anteriorly, then you will be able to see the artery coursing behind the bulla along the skull base. So you can definitely, avoid injury to it. Number two, sometimes you have a massive disease in the region of the anterethmoidal artery and you are not able to identify it with a lot of polyposis there. Our concern for the arterial injury are on the either side. When it leaves the orbit, it can be transected and enter into the orbit and give orbital hematoma. Medially, where it enters into the lateral lamella, the injury can lead to CSF leak. So in all those situations, difficult situations where you want to uncover the artery and work around it, stay in the middle of the course between the orbit and the lateral lamella, orbit and the middle turbinate. In the middle of the course, even if you injure the artery, you can coagulate there without giving any problem. So working on the extremes, laterally or medially, can injure the, can give definite, remarkable injury. Otherwise, in the middle course, even if you injure, bleeding is hardly from this 0.89 mm vessel, hardly an issue. The issue is retraction on either side to give bleeding, which can be prevented by walking in the middle of the course.
Okay, and I hope that our audience is very much satisfied with you. Maybe we will be together tomorrow also. I hope. I will talk to you later on. So thank you very much. Thank you, audience, and thank you, Dr. Satish Jain again.
Thank you.
Friend and our mentor.
Thank you very much.
Now, I request our participants to have an official picture in this position. Yes, those who are faculty, they will sit in front and we will be in behind. Okay. Jim Kota, Jim. After taking picture, I will go for one point basically, let's try to save and check for the artery. Take 70